Thank you very much for inviting me. So I thought I'd talk to you a little bit about our innovations, both for prior to surgery and also after surgery. Normally I'd acknowledge my conflicts. Well, I'm actually talking about some of these innovations from some of the spin-out companies that we have from Aston University, which is where I'm based, but principally the ones relating to Wolffsohn Research and Aston Vision Sciences. So first of all, prior to surgery, one thing that surgeons now acknowledge more than ever is the importance of the ocular surface and the quality of that ocular surface, both for doing their biometry, but also then in terms of the quality of vision that they get and not inducing dry eye type symptomology, taking someone who has ocular surface disease or damage and then doing ocular surgery on them. And likewise, if we're doing presbyopia with other options such as contact lenses, again, your ocular surface is really important. So one of the innovations that we've been working on is better ways of assessing the tear film and the ocular surface. So this is a way of doing it. You'll all be familiar with children's toys, particularly around sort of fireworks, where they're spinning something around with lights on it, and as far as your vision is concerned, you get a lovely circle of light. Well, essentially this uses the same technology, so it's a wand of light where we can control the colors along that wand and the spacing of those lights to create a persistence of vision. So essentially a complete circle or a complete plane of light on the patient's eye, and yet with a relatively low level of illumination. So we're not making the patient uncomfortable or bleaching the image that we're getting at all. So essentially we can create images either of things like rings, where we can then detect the separation of those rings to look at ocular surface shape. We can look at the breakup of those rings to look at the tear film itself, or we can create a constant image to get good quality imaging of the anterior eye or things like the meibomian glands. And we can do that with a relatively small device. This is the prototype here, and we can do that either with the stability of a slit lamp base, or we can do it as a standalone instrument that you use on a patient in their individual environment. And then with the software, of course, then we can do images and reports based on that. So some fairly simple technology, and at the end of the presentation, I'll loop back to this idea of a good ocular surface and taking information from that. But let's move to a different concept now, and this really is one about following up patients, and this is one of the companies that I work very closely with, and that's Rayner in the UK. And so they've developed a digital platform for their surgeons to help follow up patient outcomes, because again, this is becoming increasingly more important with the need to for manufacturers, of course, to collect data on the ongoing use of their devices post regulation and registration, but also for surgeons in terms of audit and to show quality. So this is a cloud-based system that works on any of your sort of smartphone or tablet type devices. And essentially it can assess the quality of care delivered to patients from a patient's perspective, the health gains after surgical treatment, and do that over time. How does it work? Well, essentially the system requires the surgeon to register the patient at the time of surgery and the lens that they've been fitted with. But by giving some simple information, then the patient receives an email from the system telling them that they've been registered and asking them at various time points to fill in some basic information. That's available to the surgeon then over time, and I'll show you these screens to map how that they're doing, but also in terms of the company, then for them to see how their product is doing with in the real world. And it's not a medical device, it's just purely a way of collecting information. So in terms of the registration, very fast and simple, some very basic information about the patient and obviously their contact details so that the app can contact them, but also then information about the hospital itself. So again, that the information can be sent back to the surgeon. The patient then gets a friendly email to themselves telling them about the surgery that they've had and explaining what it's going to ask them to do over time. And then they can fill in some very simple information about how they're feeling about their surgery, for example. Takes less than 5 minutes, and that information is then built over time. So in terms of when the data is collected, initially 1 week after surgery, then there's more information about their satisfaction with the outcomes and their spectacle independence and target vision after 3 months. More information at a year, again, in terms of satisfaction. And then finally, some data about additional procedures, any additional procedures that they've needed to have done at 2 years, and then finally 3 years after surgery. So you can see very quickly this information is building up. You as the surgeon or the practice don't need to be following those patients through. That's done automatically for you, and that then populates your own dashboard in terms of the patients that you've fitted and the information that they've collected. Likewise, it can generate then some information for you in terms of how well your patients are doing compared to other people's patients. Of course, private information for you, but potentially useful in terms of how you move forward, and then a whole load of benefits for you as a surgeon. And I can well imagine that more of these systems will appear in future to allow us to better track those patients over time. And now let's flick to some of the apps that we've developed really for, again, pre and post surgery or contact lens fitting, any type of presbyopia correction, where we're trying to collect information on patients in a better and more standardized way. And the way we principally do this is using the iOS platform, so Apple devices. The main reason being is that their screens are very standardized, so we know what we're getting in terms of luminance and contrast and resolution. And also the devices can talk to one another, and that has huge advantages in terms of presenting stimuli at different distances. So we can have everything from a simple acuity chart. So essentially with a tablet or a phone, we can take control of a distant screen through Apple TV. And so literally you can swipe and mirror your screen, but actually instead of having to do a complete mirror, the app automatically knows that one is a distant screen where you present then your letter acuity target, but actually on your near screen, it can give you a series of letters. I'll show you in the next screen that you can score yourself. So we can do things like distance visual acuity with a tablet or a phone and a monitor, or you can then do near acuity. Of course, the advantage of doing things like distance acuity for presbyopia is we can do defocus curves, so we can rapidly move through a series of presentations. We can randomize the letters, for example, so we don't have any of those issues. And you can point directly to the line that they got to last time to help in terms of getting them quickly through what can either be a very onerous test. At intermediate and near then, we can use the phone to be the remote for the iPad, and we can do that at any distance that you prescribe for the patient. And literally on the remote, you can click a letter that they don't get correct. It automatically scores that for you. And when you get to a scoring criteria of 3 out of 5 incorrect, it will automatically give you those values. So again, you're not having to work it out or hope that the technician has done that correctly for you. And again, clicking on a line automatically indicates to the patient where you want them to read. We can move forward and actually use more features of these devices. So for example, in reading speed, we've mimicked the Radner test, but actually it listens to their voice. So it can accurately time the beginning and the end of the presentation. It's watching their face and the distance between the eyes. So we actually know how far away they're holding the device, if they're cheating and bringing things closer to them. And at the end, it can automatically plot out their curve, give you their normal reading speed, their critical print size, and their threshold visual acuity. When it comes to contrast sensitivity, again, we can take advantage of the app and the presentation originally by Campbell and Robson in the 1950s of what that function actually looks like to a patient. But instead of with your individual tests having to measure one spatial frequency or maybe a couple depending on which test you use, CSV 1000, we can do 4 spatial frequencies. But actually with an iPad, you can literally just trace your finger over where you see the tops of the bars, and you've got a complete contrast sensitivity function in less than 30 seconds. And we can also do that at distance. Obviously, they can't reach and touch the distant screen, so they use the iPad to lift up the bars to be the appropriate distance. We can also do other things. This is a test that we're working on now, dynamic visual acuity. So very short presentation of a Land-Alt C in one of 4 directions with crowding bars. And again, this has been used in things like sports vision to really tease out differences in visual acuity. Moving on to glare, obviously the last presentation included that as well from Scott. We use a halometer that we've built, so a sleeve that goes onto an iPad and allows us to move a target from behind seeing to non-seeing. When they first see it, they let you know, and then you can randomize it, check that they can really see it, and you can plot out a complete profile then of their seeing curve. And we've shown that this is able to differentiate, for example, different patterns with different types of intraocular lens, multifocal intraocular lens, and also then things like segmented lenses. In terms of patient satisfaction, some people will be familiar that we did a near activity visual questionnaire a number of years ago, and that's been extensively used in the literature. But of course, it's come out of date now that we've got all of these modern devices that people are using for near as well. We've also collaborated with people like Tariq Aslam to have a look at their subjective questionnaire, and we'll tie those in together in a moment. But we're now updating that questionnaire with Novartis for their clinical trials, so there'll be a new version available. And again, we have that in an app form to make it easy for patients. But Scott was talking to you about the multifocal acceptance score. Well, we have something similar. So essentially, you can take their objectively measured glare, and if you divide that by their subjectively reported glare before surgery, of course, they've got cataract, they've got some glare there, we can actually create a score. And the higher that score is, the more likely they are to be satisfied, because actually the amount of glare that's objectively there doesn't bother them that much. Conversely, if you get a very low score, it suggests that actually psychologically they can't cope with the glare even from cataract, and therefore are less likely to be successful with a multifocal. And then finally, just to tie back into how I started in terms of assessing tear film, we have more sort of dynamic apps. This is one that we've developed to look at dry eye. So when you start the test, it allows you to relax your eyes. What we're actually measuring at that time is their blink rate. You can see the camera appear there where they're out of line. So that's what it's doing. It's analyzing their facial features and how they're blinking during this process. And then as it moves on, you'll see some questionnaires. So these are the standard dry eye questionnaires, initially the DQ5. Then it moves on to the OSDI. And so you can answer the 12 questions of the OSDI. And all while it's doing this, it's actually watching the patient. So it's looking at how they blink, for example. So we get information about their blink rate, their completeness of blink. You'll see that in a moment with the video when it analyzes that. So here's that standard questionnaire. Takes a little bit of time to get through the OSDI. Sandy's another one. So Sandy's one that has 2 scales on frequency and severity. And at this point, they would hand it back to the examiner. But actually what's happening is it's analyzing their face. You can see I did this with one of those plane trips that we'll dream about in the future because we can't get out of our countries. But essentially, it's taking all that information about my eyes and how I was using them during that. It can monitor the distance I was away and the tilt of the screen. and all that information is available there for you. And then you'll see it will actually give you that information in terms of the time of each blink, and you can go back and review that. So here we go. So it's done its analysis. So these are each of the blink times, and you can click on any of those to check the blinking at that particular point of time, and then it's got all of that data for you. So there's amazing power in what we can do with this app type technology. So thank you very much for your attention.